1 millimeter. I mean, that is literally the distance between a routine, completely successful hip surgery and just a catastrophic, life-threatening bleed.
Oh, absolutely. A bleed that can fill the human pelvis with blood in, a matter of seconds.
Right. Which is terrifying. It's the distance between restoring a patient's ability to walk and paralyzing their leg permanently. So, welcome to the deep dive.
Yeah, glad to be here.
Today, we're not just looking at a neat, color-coded textbook diagram. We are stepping into the incredibly dense, highly variable, and frankly terrifying world of applied surgical anatomy.
It really is the ultimate high-stakes environment. I mean, if you were preparing for a major surgical examination like, say, the FRCS in trauma and orthopedics, you have to understand that examiners are not just testing your ability to memorize a list of Latin names.
Right. They don't care if you can recite a dictionary.
Exactly. They are testing whether you know exactly where those hidden bombs are buried before you make your very first incision.
Which brings us to the mission of today's session. We have combed through a massive stack of surgical science modules, specifically for the applied anatomy of the spine and the lower limb.
The really high-yield stuff.
Yeah. And because we know you're likely listening to this while driving or at the gym or maybe scrubbing in, you can't take notes. So we are going to build this knowledge directly into your audio muscle memory.
To do that, we're operating under a very strict framework today. We call it the examiner's playbook.
Boo playbook.
Right. Because for any surgical approach anywhere in the body, examiners ultimately only care about three things. Number one, what is the nervous plane you are dissecting through?
Okay, what's the plane?
Yeah. Number two, what specific structure are you about to damage if your retractor slips? And number three, and this is the devious one, is there even a true internervous plane in the first place? Or, are you walking into a trap?
I love that third question because it entirely punishes assumption. Like you just assume there's a safe path. But I want to add a fourth rule to that playbook, a sort of through line we need to carry through this entire deep dive.
Let's hear it.
It's just a biological truth, right? Danger structures always live at predictable bony landmarks.
Oh, that's incredibly true.
Yeah, because the soft tissue shift, muscles atrophy, fat gets in the way, but the bone is absolute.
Yeah.
If you know the bony landmark, you know the bomb hiding right behind it.
That is a phenomenal anchor to keep in mind. Now, a really quick formatting note on how we are going to train your recall today.
Yeah, this is important for you listening.
Because you cannot write this down. Every single key structure and every major exam discriminator will be stated twice.
We're going to hammer it in.
Right. We will intentionally repeat the critical data points. And furthermore, we're going to wrap up every anatomical region with a single, highly compressed, if you only remember one thing, summary line.
So no visual aids, no, as you can see here, nonsense. We are going to describe every millimeter in words, explain exactly why the human body evolved this way, and leave you ready for the operating room.
Sounds like a plan.
So let's start at the very top of the axial skeleton and work our way down. We are looking at the anterior approach to the cervical spine.
Right, the front of the neck.
Yeah. If a surgeon is going through the front of the neck to reach the cervical vertebrae to, say, fuse a disc, what is the classic hazard lying in wait?
The absolute classic heavily tested hazard is the recurrent laryngeal nerve. I'll say that again, the recurrent laryngeal nerve.
And what does that do exactly?
It's the nerve that provides motor function to your vocal cords. So if you damage it, the patient wakes up with a hoarse voice. But if you sever both sides, they can actually lose their airway entirely.
Wow. Okay, so geographically, the front of the neck is incredibly crowded real estate. I mean, you have the trachea for air, the esophagus for food, the carotid arteries taking blood to the brain. Where exactly is this nerve hiding in all that traffic?
It lives in a very specific narrow valley called the tracheoesophageal groove.
Tracheoesophageal, okay.
Yeah. So picture the firm cartilaginous rings of your trachea, your windpipe in the front. Just behind that, sitting totally flat against it, is the soft muscular tube of your esophagus.
Right.
Where those two cylindrical tubes press together, they create this natural anatomical gutter on the side. That gutter is the tracheoesophageal groove, and that is exactly where the recurrent laryngeal nerve travels upward toward the voice stalks.
Now, in my head, I'm trying to visualize the actual surgery, right?
Yeah.
The surgeon isn't usually in there wildly hacking away with a scalpel right near that groove. So how does the nerve actually get injured? Are we, like, stretching
Yeah,
it.
you're crushing it. It is an injury of compression, and it actually involves two opposing forces.
Okay.
To get to the spine, the surgeon has to place these heavy metal retractor blades deep in the neck to hold all those vital tubes out of the way. Meanwhile, the anesthesiologist has a breathing tube placed down the patient's trachea to keep them alive.
Right, the endotracheal tube.
Exactly. And that tube has a firm, inflated balloon cuff to secure it inside the airway.
Oh, I see it now. The nerve is caught in the middle of a vise.
Precisely. The recurrent laryngeal nerve gets crushed between the hard metal retractor blade pushing from the outside and the inflated, rigid cuff of the endotracheal tube pushing from the inside.
Which means the surgical workaround doesn't actually require the surgeon to do anything differently, does it? Like the fix has to come from the head of the bed from anesthesia.
That is exactly right. And it is a highly testable clinical pearl. After the surgeon places the retractors and cranks them open to expose the spine, the tissues are under immense tension.
Right.
The anesthesiologist simply deflates the breathing tube cuff for just a few seconds. That allows the trachea to shift, the nerve slips out of that pinch point, and then they just gently re-inflate the cuff.
That's brilliant. That simple deflation saves the nerve.
It really does.
So let's talk about those retractors for a second, because we have to pull things in the right direction. Common sense tells me I want the major blood vessels far away from my drill. So how are we parting the Red Sea here?
You split the neck contents into two distinct packages. The carotid sheath and all its vital contents, so the carotid artery, the internal jugular vein, and the vagus nerve, they go laterally.
You pull them outward.
Right, away from the midline. Then the viscera, meaning the trachea and the esophagus, they go medially. You pull them inward across the center of the neck.
Got it.
When you pull the vessels out and the tubes in, the bare cervical spine sits right there in the middle, totally ready for surgery.
Okay, here is where my reading of the source material threw up a major red flag, like a total paradox.
Oh, what did you find?
Well, one major exam source explicitly states that going in on the left side of the neck is safer. But then another paper heavily emphasizes the dangers of the right-sided approach. If I'm holding a scalpel, why is one side of a seemingly symmetrical neck suddenly a trap?
This is where examiners really separate the rote memorizers from the deep understanders. Because the human body is not perfectly symmetrical, and this paradox is entirely rooted in embryology.
Okay.
The left-sided approach is traditionally safer. And the reason is that the left recurrent laryngeal nerve is highly predictable.
What makes it predictable, though? Why does the left one follow the rules?
Because of where it anchors. During fetal development, the heart and major vessels pull downward into the chest. The left recurrent laryngeal nerve gets caught under the massive arch of the aorta.
Oh, wow.
Yeah, it gets dragged all the way down into the deep chest, loops securely underneath the aortic arch, and then travels straight back up the neck. Because it loops under such a massive, fixed, immovable structure, its path upward through that tracheoesophageal groove is incredibly consistent.
But the right side didn't get dragged down by the aorta.
No, it didn't. The right recurrent laryngeal nerve loops much higher up, catching under the right subclavian artery instead of the aorta.
So it doesn't go into the chest at all.
Right. Because it doesn't travel into the deep chest, its path back to the larynx is much shorter. Consequently, it is highly variable. It tends to exit its protective sheath much higher up in the neck, and it often runs at this unpredictable oblique angle right across the surgical field.
Let me get this straight. A left-sided approach gives you a nerve safely tucked in a gutter. But a right-sided approach gives you a nerve that might be wandering diagonally right across your incision line.
Exactly. The left approach is safer because it's predictable. The right side is riskier because the nerve exits higher and is super variable.
Man, that is fascinating. Okay, let's apply rule number 4, danger structures and bony landmarks. I have made my incision. I am looking at the cervical spine. I cannot just start counting vertebrae from the skull down to figure out where I am.
Right.
Because I haven't exposed the whole neck. I need landmarks I can feel with my fingers.
Right. You navigate by palpation often before you even make the skin incision. And there are 3 distinct levels you absolutely must know.
Walk me through them.
High up in the neck, right where the soft tissue under your chin meets your throat, you can feel a hard U-shaped bone. That's the hyoid bone. And the hyoid bone sits at the level of the C3 vertebra.
Okay, hyoid is C3. What if I track my fingers further down the midline?
You'll pass over the prominent thyroid cartilage, which is the Adam's apple, and just below that you will feel a firm, complete horizontal ring of cartilage. That is the cricoid cartilage.
Cricoid.
Yes. The cricoid cartilage perfectly marks the level of the C6 vertebra.
And there is a bony anchor right next to it, isn't there? Like a danger landmark.
Yes, there is. If you slide your finger just lateral to the cricoid cartilage, pressing deep onto the spine itself, you'll feel a prominent bony bump. That is the carotid tubercle, historically known as Chassagnac's tubercle.
So it's right on C6.
Exactly. It sits right on the anterolateral border of C6.
Let me guess the danger here. It's called the carotid tubercle because the carotid artery sits right on top of it.
You nailed it. It's a critical landmark because if a patient has massive bleeding in the neck, you can physically press the carotid artery back against the specific tubercle on C6 to compress the vessel and stop the bleed.
Incredible. Okay, so hyoid is C3. Cricoid and the carotid tubercle are C6. Let's lock this region down for you listening. If you only remember one thing from the cervical spine. The recurrent laryngeal nerve is the primary danger. The left-sided approach is safer because the nerve's long course under the aorta makes it predictable, and the cricoid cartilage and carotid tubercle reliably mark the C6 level.
We are building the map.
We are. So let's travel down the axial skeleton to section 2, the lumbar spine and the disc. We just established how delicate the nerves in the neck are, but as those nerve roots exit the lower back to feed the legs, the way we name them and find them completely changes.
Oh, completely.
The lumbar spine numbering convention is like legendary for failing candidates.
It really is deeply counterintuitive, at least until you visualize the physical architecture of the bones. In the cervical spine, nerves exit above their corresponding vertebra. But in the lumbar spine, the rules flip.
What's the unbreakable rule here?
The rule you must memorize is this. In the lumbar spine, the exiting nerve root is named for the pedicle above it, and it leaves very high up in the neural foramen.
Okay, I have a way to visualize this that always helped me. Imagine a lumbar vertebral level is a train station.
A train station. Okay, go on.
So let's look at the L3, L4 level, the disc space between the third and fourth lumbar vertebrae.
Right.
At this L3, L4 station, two trains are passing through. The L3 train is the exiting route. It is actively leaving the main line, pulling off the tracks, and exiting high up through the side door, which is the foramen.
Okay, yes.
Meanwhile, the L4 train, which we call the traversing route, ignores the exit door entirely. It stays central and continues straight down the main tracks to exit at the next station down.
That is a flawless mechanical analogy. The exiting route takes the name of the vertebra above the disc space. At L3, L4, the L3 route exits, while the L4 route traverses.
But patients don't show up in the clinic talking about train stations, you know. They show up screaming in agony because they blew out a disc lifting a heavy box.
Yeah, the real-world application.
Exactly.
Yeah.
And where that disc blows out dictates exactly which train gets derailed.
Exactly. And examiners will give you a specific type of disc herniation and ask you to name the compromised nerve. So let's say the patient has a paracentral disc herniation at L3, L4.
Okay.
This means the disc bulges straight backward and slightly to the side into the main central spinal canal.
Well, if it bulges centrally, it's going to completely miss the L3 exiting route, right? Because the L3 already took the side door and left the building.
Precisely. That paracentral disc will smack directly into the traversing L4 route that is continuing its journey downward. So a paracentral disc at L3, L4 hits the L4 route.
But what if the disc material shoots way out to the side? What if it's a far lateral herniation?
If the disc blows out far laterally, straight into the foramen itself, it acts like a roadblock at the side door. In that scenario, it crushes the nerve that is actively trying to leave. So a far lateral disc herniation at L3, L4 hits the exiting L3 route.
So paracentral hits the traversing lower number, far lateral hits the exiting upper number.
Exactly.
That just requires pure 3D spatial awareness. Now let's pivot from the back of the spine to the front. Suppose a surgeon needs to fuse the L4, L5 disc from the front. Maybe it's completely collapsed. This requires a retroperitoneal approach, going through the abdomen but staying entirely behind the sac, holding the intestines.
It is a massive, highly intimidating exposure. I mean, you are sweeping the abdominal contents to the side to stare directly at the front of the spine. But lying right on top of that bone are the largest blood vessels in the human body, the aorta and the inferior vena cava.
To get to the bone, you literally have to move those massive vessels. But you can't just shove them out of the way with a metal retractor, can you?
If you blindly retract those vessels at the L4, L5 level, you will cause a catastrophic hemorrhage.
Because of a tether.
Yes, because of a tiny anatomical anchor. To expose L4, L5, you absolutely must ligate the iliolumbar vein. Let me repeat that hazard. To safely access L4, L5, you must ligate the iliolumbar vein.
What makes this specific vein such a nightmare?
It's just a matter of physical dimensions. The iliolumbar vein is incredibly short, it's disproportionately fat, and it acts as a rigid tether, pinning the massive common iliac vein tightly to the side of the lumbar spine.
Wow.
Yeah, if you apply a retractor to the great vessels without tying off and cutting the iliolumbar vein first, that short, fat vein will not stretch. It will simply tear a massive hole in the side of the common iliac vein.
And tearing the common iliac vein means you have high-volume venous blood filling that deep retroperitoneal space in seconds. You won't even be able to see the hole to fix it.
It is a fast track to losing the patient on the table. You must dissect it out and ligate it.
Right.
Now, what if the surgeon is operating one level lower, down at L5-S1, right where the spine meets the pelvis? Does the hazard change?
I would assume the anatomy changes because the aorta splits into the iliac arteries right around the belly button, doesn't it?
Exactly. Right at L4, the aorta bifurcates.
Yeah.
So by the time you reach the L5-S1 disc space, the main vessels have split and moved laterally, but nature left a trap running right down the middle.
Of course it did.
As the aorta splits, it sends a smaller set of vessels straight down the midline, draped directly over the L5-S1 disc. So at L5-S1, the specific hazard changes to the middle sacral artery and vein.
Okay, so iliolumbar vein for L4, L5, middle sacral vessels for L5-S1. Got it. Now let's go back to our rule about soft tissue dangers lying on bony landmarks. As we are doing this retroperitoneal sweep, moving the intestines aside, we come across the massive psoas muscle.
The main hip flexor, right?
Yeah, running alongside the spine. What hidden bomb is lying right on top of it?
Lying totally exposed on the anterior surface of the psoas muscle is the genitofemoral nerve. It originates from the L1 and L2 nerve roots. Because it sits naked on the muscle belly, if you lazily place the tip of your retractor directly onto the psoas muscle and pull, you will crush the genitofemoral nerve.
And what's the result of that?
The patient will wake up with chronic, intractable, burning pain in their groin and thigh.
Oh, that sounds awful. Okay, let's zoom in microscopically on the actual intervertebral disc itself. We hear patients complain about disc pain constantly. But a disc isn't just a uniform hunk of rubber, right? Biologically, what part of this structure is actually capable of feeling pain?
It is a massive misconception that the entire disc is a sensitive pain generator. The anatomy is highly specific. Only the very outer wrapper of the disc, the annulus fibrosus, and the periosteum covering the vertebral bones are innervated.
Only the outer wrapper?
Yes. They feel pain via a tiny, highly sensitive nerve branch called the sinuvertebral nerve.
So the tough outer wrapper feels pain. What about the jelly-like center, the part that actually herniates?
The center, the nucleus pulposus, is completely devoid of nerve endings. It is strictly insensate. I'll repeat that exam discriminator. The nucleus pulposus is strictly insensate. It cannot feel pain whatsoever.
That perfectly explains the clinical reality of disc degeneration. Like you could have a nucleus pulposus that is breaking down, desiccating, and shifting inside your spine for 20 years, and you wouldn't feel a thing.
Exactly.
The pain only triggers when that silent jelly pushes outward hard enough to tear the innervated outer annulus, or, until it bursts out and hits a spinal root.
Exactly. The pathology is entirely silent until it hits the wiring.
While we're looking at the disc, explain the mechanics to me. Form always follows function in orthopedics. Why is the outer annulus fibrosus built to be so incredibly tough? What forces is it fighting?
The outer annulus is an engineering marvel designed specifically to resist tension and torsion, meaning pulling and twisting forces. To survive those forces, it is constructed out of dense type I collagen.
But it's not just a random mesh, right?
No, the collagen fibers are organized into alternating concentric rings called lamellae.
Like the layers of a radial tire.
That is the perfect analogy. Each layer's collagen fibers are angled at roughly 30 degrees to the horizontal disc space, and the very next layer is angled at 30 degrees in the exact opposite direction.
Oh, I see.
This alternating crisscross pattern gives the annulus immense tensile strength against rotational forces. When you twist your torso, half the fibers pull tight to stop you from tearing your spine apart.
And what about the insensate jelly center, the nucleus pulposus? What is its mechanical job?
If the annulus resists tension, the nucleus pulposus exists entirely to resist compression. It absorbs the downward shock of gravity. Biologically, it is made largely of a specific proteoglycan called aggrecan, which acts like a sponge that aggressively attracts and holds water.
Like a shock absorber.
It functions exactly like a highly pressurized water balloon. It absorbs the downward compressive force of your body weight and translates it outward against that strong, fibrous annulus.
So the nucleus handles the compression, and the annulus handles the tension. It's a flawless biomechanical system. Let's lock this section in for you listening. If you only remember one thing about the lumbar spine, the L3-L4 exiting route is L3, while the traversing route is L4. You absolutely must ligate the iliolumbar vein to access the L4-L5 space safely. And finally, the outer annulus and periosteum feel pain, but the inner nucleus pulposus is completely insensate.
We have the spine mapped.
Yeah.
Now we must trace where those nerves actually go.
Which flows perfectly into dermatomes and myotomes. We have just established exactly where these lumbar nerve roots exit the bony spine. But the examiner's playbook demands we seamlessly map where those specific nerves supply feeling and motor function down in the lower body.
This is the wiring diagram of the human body. A dermatome is an area of skin supplied by a single specific spinal nerve root. A myotome is a group of muscles innervated by a single root.
Right.
And here is the trick for the exam. They are not going to ask for vague, overlapping regions. They will ask for absolute, non-negotiable anchor points.
I love anchor points. Let's map the lower limb. We are going to start with the sensory map, the dermatomes, down in the leg. Give me the anchor point for the L4 nerve root. Where does L4 provide sensation?
When you hear L4, I want you to think medial. The L4 dermatome covers the medial aspect of the leg, the medial side of the foot, and specifically the great toe.
So the inside of the calf, the inside of the foot, and the big toe. That is L4. What about L5?
For L5, move outward. L5 covers the lateral aspect of the leg, the middle toes, specifically toes 2, 3, and 4, and the broad top surface, the dorsum of the foot.
Medial is L4, lateral calf, and top of the foot is L5. And finally, S1.
S1 moves all the way to the outside edge. It covers the lateral aspect of the foot and the little toe.
This is so critical. I'm going to summarize the sequence because it is heavily tested. Medial leg is L4, lateral leg is L5, lateral foot is S1.
Let me repeat it just to enforce it. Medial leg is L4, lateral leg L5, lateral foot S1. If you just remember that progression inside, outside, outer edge, you will instantly catch the vast majority of sensory exam questions.
But wait, why is it mapped like that? Why does L4 go to the inside of the leg, but L5 wraps around the outside? It feels like the wires got crossed on their way down from the spine.
They did get crossed. And to understand why, you have to look at evolutionary embryology. This is the secret to not just memorizing the dermatomes, but actually understanding them.
Okay, I'm listening.
During fetal development, right around week 4, your limbs start as tiny buds sticking straight out from the sides of your body, with the thumbs and big toes pointing upward toward the head.
Like little flippers.
Exactly like flippers. If they stayed like that, the dermatomes would run in perfect, straight, horizontal stripes. But they don't stay like that. As the fetus develops, the lower limb buds internally rotate almost 90 degrees.
Wow.
This massive rotation essentially wrings out the dermatome map like a wet towel, dragging the nerves into a spiral pattern down the leg. That fetal rotation is exactly why L4 spirals to the inside and L5 spirals to the outside.
That is an incredible visual. The fetal limb bud rotation literally creates the spiral map. So we've mapped the lower leg and foot. How do we march back up the thigh?
Marching the anterior thigh is delightfully logical. It just follows a strict sequence from top to bottom. L1 covers the proximal third of the thigh, right up high near the groin crease.
Okay.
L2 covers the middle third of the thigh. L3 covers the distal third of the thigh, extending down to cover the medial aspect of the knee.
Top, middle, bottom. L1, L2, L3. That is almost suspiciously easy for a surgical syllabus.
Yeah.
What about the trunk, the torso itself? If a patient has a spinal cord injury, examiners love to test the horizontal sensory levels on the chest and abdomen.
There are 3 critical, non-negotiable horizontal bands to memorize on the trunk. T4, the forethoracic root, provides sensation exactly at the level of the nipple.
T-core is the nipple.
T10 aligns perfectly with the umbilicus, the belly button. And T12 marks the level of the groin, right at the inguinal ligament.
So T4 is the nipple, T10 is the umbilicus, T12 is the groin. Now, T10 at the belly button is fascinating to me clinically. When a patient gets appendicitis, the appendix is supplied by the T10 nerve level.
Right.
But the appendix isn't in the center of the belly, right? It's down in the lower right corner. Yet, the classic first symptom of appendicitis is a vague, aching pain right around the belly button.
Yes, that is the perfect real-world application of this anatomy. The brain gets a distress signal from the T10 nerve wire. But the brain can't easily distinguish whether that signal is coming from the visceral organ, the appendix, or the skin dermatome, the umbilicus, because they share the exact same embryological wiring.
Oh, that makes so much sense.
So the brain misinterprets the source, and the patient feels referred pain at the belly button before the local inflammation finally shifts the pain to the lower right side.
So that covers the sensory map.
Mm-hmm.
Let's transition to the myotomes, the motor function. Is there one specific myotome that examiners obsess over in the lower limb?
Without question, the most heavily tested lower limb myotome is L5. The primary absolute exam discriminator for L5 motor function is testing the extensor hallucis longus muscle.
Which does what in plain English?
It is the muscle that lifts your big toe up toward the sky. If you ask a patient to pull their big toe up against the resistance of your hand, and they simply cannot do it, you instantly suspect an L5 nerve root compression, likely from that far lateral disc herniation at L4, L5 we discussed earlier.
So L5 lifts the big toe. Is there anything else L5 powers that we need to know?
It also contributes to the extensor digitorum, which lifts the remaining 4 toes, and crucially, it heavily supplies the gluteus medius muscle up in the hip, which we will see is vital for keeping your pelvis level when you walk.
Okay, before we take a scalpel to the hip joint, let's take a quick mental checkpoint of everything we've just built. This is mid-episode recap 1 for you listening.
Let's do it.
If you only remember one thing about dermatomes and myotomes, L4 covers the medial leg, L5 covers the lateral leg and powers big toe extension, and S1 covers the lateral foot. On the trunk, T4 is the nipple, T10 is the umbilicus, and T12 is the groin. And remember, the spiral of the leg dermatomes is caused by fetal limb bed rotation.
The foundation is set. Let's move to the hip.
We are taking our freshly drawn nerve map down into the surgical realities of the hip joint itself. And this is exactly where the examiner's playbook trap of the non-existent internervous plane really comes out to bite candidates.
It is the most critical concept in surgical approaches. In a perfect textbook world, every time a surgeon needs to cut deep into a limb, they can find a natural anatomical pathway between 2 different muscles that are supplied by entirely different nerves.
Right.
That pathway is a true internervous plane. If you gently pry those 2 muscles apart, you don't stretch or cut the power supply to either of them, so you don't cause any paralysis.
Because neither muscle's electrical cord is crossing the gap you are splitting?
Exactly. The gold standard example of a mathematically perfect, true internervous plane is the Smith-Peterson approach, which is the anterior approach to the front of the hip.
Let's dissect the Smith-Peterson right now.
Yeah.
What are the 2 muscles we were slipping between?
On the medial side of your dissection, you have the sartorius muscle, which is supplied by the femoral nerve. On the lateral side, you have the tensor fasciae latae, or TFL muscle, which is supplied by the superior gluteal nerve.
Okay. Femoral nerve on one side, superior gluteal nerve on the other. That is a true internervous plane.
Yes.
But the playbook dictates we have to know the damage. Nature doesn't leave empty spaces. What structure is sitting in that gap waiting to be ruined when I put my retractor in?
There are 2 specific dangers crossing that gap. The arterial danger is the ascending branch of the lateral femoral circumflex artery.
Ascending branch.
Right. I must repeat that because it is guaranteed to be tested. The ascending branch of the lateral femoral circumflex artery. You will encounter it crossing your path, and you absolutely must isolate and tie it off, or it will retract and bleed heavily into the wound.
What about the neurological danger? What nerve is at risk in this anterior Smith-Peterson approach?
The lateral femoral cutaneous nerve. It is a purely sensory nerve that runs right down the front of the thigh, often varying slightly in its course. It is very easily stretched by retractors or accidentally cut when making the initial incision, leaving the patient with a numb patch on their thigh.
Okay, so Smith-Peterson is a true plane, but watch out for the ascending branch of the lateral femoral circumflex artery. That's the ideal scenario. But I have to ask the obvious question. If true planes are so beautifully safe for muscle function, why do surgeons ever use approaches that don't have them? Why deliberately choose a risky path?
It's a trade-off between neurological safety and mechanical access. The anterior true plane is great for certain things, but it is a really narrow window.
Right.
It does not give you a great view of the back of the hip joint, and for placing certain types of artificial hip implants, like a standard total hip arthroplasty coming from the front, can make it biomechanically difficult to position the metal cut perfectly. Sometimes, to get the mechanics of the joint replacement right, you simply have to come from the side of the hip. And that leads us to the trap planes.
The traps. Let's look at the Watson-Jones approach, which is the anterolateral approach.
Yeah.
Why is this considered a trap?
Because on the surface, the Watson-Jones approach looks like a true plane. It goes between the tensor fasciae latae muscle and the gluteus medius muscle. The problem is, both of those muscles are supplied by the exact same nerve, the superior gluteal nerve.
Oh, I see the trap.
If both muscles run off the same nerve, there is, by definition, NO, true internervous plane. If you pull them apart too forcefully or if you dissect too deeply into the muscle bellies, you risk tearing the delicate branches of the superior gluteal nerve that are physically bridging the gap between them.
And just as a quick aside on the Watson-Jones, to get deep enough, you also have to detach the reflected head of the rectus femoris muscle. And if you blindly place a retractor too far medially over the psoas muscle, you risk compressing the mighty femoral nerve and vessels.
Yep.
So Watson-Jones has no true plane. What about the Hardinge approach?
The Hardinge approach is a direct lateral approach, and this one is even more blatant in its disregard for planes. It doesn't even pretend to slide between two different muscles.
Wait, what does it do?
To get to the hip joint, the Hardinge approach literally splits the fibers of the gluteus medius muscle right down the middle.
And since a single muscle can only be supplied by one primary nerve.
Exactly. The gluteus medius is supplied entirely by the superior gluteal nerve. Splitting the muscle means, by definition, there is no true internervous plane.
So what is the shared catastrophic danger between these two lateral approaches, the Watson-Jones and the Hardinge? What happens if your scalpel gets sloppy?
The shared danger is the superior gluteal nerve itself. In the Hardinge approach specifically, there is a very strict geographic limit. If your longitudinal split in the gluteus medius muscle extends more than 5 centimeters above the tip of the greater trochanter, which is the big bony bump on the side of your hip, you will cut right through the main trunk of the superior gluteal nerve before it even has a chance to branch out.
Wow. And if a surgeon accidentally severs the superior gluteal nerve, what is the functional outcome for the patient when they wake up?
They permanently lose the power of their gluteus medius, and the biomechanical result is devastating. They develop a severe permanent limp known as a Trendelenburg gait.
Walk me through the physics of that limp. Why does the hip actually drop?
When you stand on one leg, which you do with every single step you take while walking, gravity immediately tries to pull the unsupported side of your pelvis down toward the floor.
Makes sense.
To stop you from falling over, the gluteus medius muscle on the standing leg has to contract fiercely to pull the pelvis level, acting exactly like a crane holding up a heavy load. If you cut the superior gluteal nerve, the crane loses power. Every time the patient steps on the affected leg, their pelvis will violently sag and drop to the opposite side.
So the surgical trade-off for better joint access is a high-stakes game of millimeter-perfect dissection to avoid causing a permanent disabling limp. If you only remember one thing about hip approaches, the Smith-Peterson approach has a real internervous plane and risks the ascending branch of the lateral femoral circumflex artery. The Watson-Jones and Hardinge approaches have no true internervous plane because they split muscles that are all supplied by the superior gluteal nerve.
Know the traps. Respect the nerve.
Which brings us perfectly into the sciatic notch and the gluteal region. We just spent a lot of time discussing the superior gluteal nerve as the ultimate surgical trap. Let's track backward and look at where these vital nerves and vessels actually exit the bony pelvis to reach the hip in the first place.
The back of the human pelvis is essentially a massive, solid, bony wall protecting the internal organs. But it has to have archways cut into it to allow the vital nerves and blood vessels to escape the pelvis and travel down into the legs. The most famous and anatomically dense of these archways is the greater sciatic notch.
Which, naturally, is where the sciatic nerve, the single largest and thickest nerve in the human body, makes its grand entrance into the leg.
It does. But applied anatomy is all about relationships. Examiners don't just want to know it exits there, they want to know exactly how it exits. The rule is, the sciatic nerve exits the greater sciatic notch below the piriformis muscle.
Whoa.
Let me state that twice. The sciatic nerve exits the greater notch below the piriformis muscle.
Describe the piriformis for me. How does it dictate the geography of the notch?
The piriformis is a distinct pear-shaped muscle that originates inside the pelvis and runs straight out through the greater sciatic notch. It acts like a horizontal dividing curtain, completely splitting that massive archway in half. Things exit above the piriformis and things exit below it. The massive sciatic nerve emerges right below that muscular curtain.
And once it emerges, what is it resting on? It doesn't just hang in empty space.
Once the sciatic nerve emerges below the piriformis, it runs straight down the back of the hip joint, draped completely over a carpet of 4 smaller muscles known as the short external rotators.
What is the sequence of that muscular carpet from top to bottom?
Sitting just under the sciatic nerve, from superior to inferior, you have the superior gemellus, the obturator internus tendon, the inferior gemellus, and the rectangular quadratus femoris. The sciatic nerve rests directly on top of all of them before it finally dives deep under the biceps femoris muscle in the back of the thigh.
Okay, so that is the greater sciatic notch. But earlier you said examiners love to test dividing lines. What physical bony structure separates the greater sciatic notch from the much smaller, lesser sciatic notch sitting just beneath it?
This brings us back to Rule 4 bony landmarks. The key divider is a sharp spike of bone projecting inward from the pelvis, called the ischial spine.
The ischial spine.
Yes, a very tough, unyielding band of fibrous tissue called the sacrospinous ligament attaches directly to this spine. Together, the bony spine and the ligament act like a structural crossbeam, physically dividing the massive hole in the pelvis into a two-story exit system, a greater notch on the upper level and a lesser notch on the lower level.
Okay, so what takes the highway through the upper level, the greater notch?
Almost everything vital to the back of the leg. The greater notch, sitting above the ischial spine, transmits the piriformis muscle, the sciatic nerve, the superior and inferior gluteal vessels and nerves, the posterior femoral cutaneous nerve, the pudendal nerve and vessels, and the specific nerves running to the obturator internus and quadratus femoris.
That is crowded.
It is a massive, heavily trafficked anatomical highway.
Which means the lower level, the lesser notch, must be pretty quiet by comparison. And in multiple choice exams, the quiet, unique structure is almost always the answer to an odd one-out question.
It is the ultimate discriminator question. The lesser notch, located below the ischial spine, primarily transmits only one major structure out of the pelvis, the tendon of the obturator internus muscle.
Okay.
It acts as a bony pulley for that tendon to hook around as it travels to attach to the femur. Additionally, the lesser notch allows the pudendal nerve and vessels, which exited the pelvis through the greater notch, to immediately loop back into the pelvis through the lesser notch to supply the perineum.
So if a test question asks which of the following structures does not use the greater sciatic notch to exit the pelvis, you scan the options for the obturator internus tendon. It uses the lesser notch.
Correct. Now, we have to address a truly terrifying surgical reality regarding the back of this pelvic bone. Often, in orthopedic trauma or spine surgery, the surgeon needs to harvest a large amount of extra healthy bone to help a complex fracture heal or to pack into a spinal fusion.
Right.
The absolute best place in the body to harvest your own bone is from the back of the pelvis, the posterior iliac crest. But there is a lethal danger hiding just down the slope of that bone.
Set the scene in the OR for me. How does this actually go wrong?
It is a scenario burned into the mind of every orthopedic resident. You are operating on the back of the pelvis. To get to the bone, you have to use a blunt metal tool called a Cobb elevator to forcefully peel the thick gluteal muscles off the side of the ilium. You are pushing hard against the bone, sweeping downward.
Sounds standard.
It is, but if you push that elevator too forcefully and the tip slips too far down the slope of the bone, slipping right into the absolute peak of the greater sciatic notch,
What do you hit?
you hit the superior gluteal artery. Let me repeat the ultimate danger of bone grafting, the superior gluteal artery. It exits the pelvis right at the very top, the apex of that greater sciatic notch, pinned incredibly tightly against the sharp bone.
And why is hitting this specific artery such a nightmare scenario? I mean, you are in a sterile operating room, you have high-powered suction, you have clamps, you have cautery. Why is this specific bleed a life-or-death exam question?
Because of the relentless physics of human blood vessels. When an artery is completely severed or torn open, the muscular walls of the vessel instantly go into severe spasm and the vessel violently retracts.
Oh, yeah.
The superior gluteal artery is so tightly tethered to the inside of the pelvis that if you tear it from the outside with your elevator, it physically snaps backward, retracting deep into the internal cavity of the pelvis.
So you literally cannot see the end of the bleeding hose to put a clamp on it.
Exactly. It retracts into a deep pelvic space that you simply cannot access from your current surgical approach on the back of the hip. The internal pelvis acts like a massive bowl that begins rapidly filling with high-pressure arterial blood, and you cannot stop it from where you are standing.
That's horrifying.
It is an absolute catastrophe. You have to flip the patient over, open their abdomen, and find the internal iliac artery to stop the patient from bleeding out. That is exactly why examiners test it relentlessly.
That is the ultimate surgical pucker factor. The margin for error is zero. If you only remember one thing about the gluteal region for you listening, the sciatic nerve exits the greater notch below the piriformis muscle. The ischial spine is the key bony landmark that divides the greater and lesser notches. The obturator internus tendon uses the lesser notch. And the superior gluteal artery is the terrifying life-threatening danger when harvesting a posterior iliac bone graft.
A literal point of no return.
Let's move to hip blood supply and the strongest ligament. Since we just touched on a catastrophic high-volume arterial bleed, let's look at a very different vascular issue. This time, an incredibly delicate, fragile, low-volume blood supply that holds the very life of the femoral head in the balance.
The hip is a ball and socket joint. The ball is the femoral head, sitting at the very top of the femur. For that dense sphere of bone to stay alive and support your body weight, it needs a constant, robust blood supply. But the way nature routed the plumbing to that ball is surprisingly vulnerable to trauma.
What is the primary pipe feeding the ball of the hip?
The main critical blood supply to the adult femoral head is the medial femoral circumflex artery. Let me state that twice. The medial femoral circumflex artery is the main supply to the head.
How does it actually reach the bone? Because the head is buried deep inside a thick joint capsule.
The artery wraps around the back of the femoral neck, deep to the muscles. From there, it sends these tiny, incredibly delicate branches called retinacular vessels. Yes. These microscopic vessels run straight up the outside of the bony neck, piercing the capsule to feed the bone of the femoral head.
And this anatomical layout is exactly why hip fractures in the elderly are so devastating, right? If an older patient falls and breaks the neck of the femur.
If the fracture is displaced, meaning the broken ends of the bone snap and shift completely out of alignment, those tiny retinacular vessels climbing up the neck are instantly sheared in half.
The plumbing is completely, permanently disconnected.
Yes. And without that vital blood flow from the medial femoral circumflex artery, the bone cells inside the femoral head simply suffocate and die. The bone crumbles and the ball collapses. This is a pathological condition called a vascular necrosis, or AVN. This absolute anatomical reality dictates exactly how orthopedic surgeons must treat a broken hip.
Let's walk through that surgical decision-making. If I am the surgeon looking at a displaced neck fracture, I know the medial circumflex vessels are torn. Pinning the bone back together with metal screws is pointless, right? Because the bone is already dead. It'll just collapse around the screws in a few months.
Exactly. You would be trying to fix dead wood.
Yeah.
Because of that specific vascular anatomy, a displaced neck fracture in an older adult dictates that you don't even try to fix the bone. You throw the dead ball away and you perform a hip replacement, a hemiarthroplasty, or total hip putting a metal ball in its place.
Is there any backup blood supply at all? If the medial circumflex is the main pipe, does the lateral circumflex help?
There is a secondary contributor, but it is minor. The lateral femoral circumflex artery, which arises from a larger deep thigh vessel called the profunda femoris, contributes to a vascular ring around the base of the neck. Its ascending branch even connects, or anastomoses, with the superior gluteal artery up above, but it is simply not enough volume to keep the femoral head alive on its own if the medial supply is severed.
Quick anatomical nomenclature question before we move on. We have a medial circumflex artery and a lateral circumflex artery. What are they medial and lateral to? What is the physical anchor point they are named around?
Excellent question. They are named medial and lateral in direct relation to the massive iliopsoas tendon that crosses the very front of the hip joint. The medial circumflex dives inside the tendon, the lateral circumflex goes outside it.
Okay, let's switch gears from incredibly fragile blood vessels to absolute brute strength. The hip joint is a marvel. It has to endure massive dynamic forces every time you take a single step, jump, or run. What soft tissue structure is actually holding this joint together?
The hip joint capsule is heavily reinforced by several thickened ligaments, but one stands entirely above the rest in terms of structural integrity. It is unequivocally the strongest ligament in the human body. The iliofemoral ligament. Historically, examiners love to refer to it by its eponymous name, the ligament of Bigelow.
The strongest ligament in the human body. Paint a picture of this thing for me. How is it arranged?
Imagine an incredibly thick, heavy-duty bungee cord shaped like a massive inverted letter Y. The top base of the Y attaches securely to the pelvis at a specific bony point called the anterior inferior iliac spine, or AIS.
Okay, the top of the Y.
Right. Then the two thick arms of the inverted Y splay downward, wrapping across the entire front of the hip joint capsule and attach firmly across the entire front of the femur along a rough bony ridge called the intertrochanteric line.
So it spans the entire front of the hip joint, strapping the pelvis to the femur. What is its biomechanical purpose? Why did human evolution dictate that this specific ligament needs to be the strongest in our body?
It is the biological reason humans can stand upright on two legs. It is the cost of bipedalism. When you stand up straight, your center of gravity falls just behind your hip joints. Gravity naturally wants to pull your torso backward, tilting your hips into hyperextension.
Right.
If you didn't have this ligament, you would fall over backward unless you constantly fired your hip flexor muscles to fight gravity.
But we don't have to think about standing. We just stand.
We don't have to think, because this massive inverted Y bungee cord pulls instantly taut as you stand up, physically locking the joint in place. You are essentially hanging on the raw tensile strength of the iliofemoral ligament. It heavily resists extension, allowing you to stand upright for hours without burning massive amounts of ATP energy in your muscles.
That is incredible. Bipedalism brought to you by the ligament of Bigelow. Before we leave the hip, let's take a mental checkpoint, our second rapid consolidation, to lock in these survival markers for you listening. Mid-episode recap 2.
Let's hear it.
If you only remember one thing about the hip's blood and ligaments, the medial femoral circumflex artery is the absolute main blood supply to the femoral head, and its disruption causes a vascular necrosis. And the iliofemoral ligament is the strongest ligament in the human body, acting as a biomechanical lock to resist hip extension and allow upright standing.
The hip is secure. Now, we travel down the femur from the massive, deeply buried ball and socket to the incredibly complex, exposed, layered hinge of the knee.
The knee is fascinating because compared to the hip, which is buried under inches of gluteal and quad muscle, the knee feels like it is right under the skin. You can feel every bump of bone and every thick tendon.
It feels superficial, but its stability relies on immense architectural precision. The easiest way to conceptualize the soft tissue stabilizing the knee, particularly on the sides, is to picture an onion.
An onion.
Yeah, onion. The knee is wrapped in distinct sequential layers of tissue. Examiners love to test exactly what structure lives in what layer.
Let's peel the onion. They love the lateral side, the outside of the knee. What are the 3 layers there?
Let's go from the skin down to the joint fluid. Layer 1, the outermost superficial layer, consists of 3 things: the iliotibial tract, the biceps femoris tendon, and the crural fascia. Let me state that lateral layer 1 twice because it is highly tested. Lateral layer 1 is the iliotibial tract, the biceps femoris, and the fascia.
Okay, so the IT band, the outer hamstring tendon, and the fascia wrapper. I peel that first layer away. What is layer 2?
Layer 2 is essentially the stabilizing tissue of the kneecap. It contains the lateral patellar retinaculum and the patellofemoral ligament.
Now the deepest layer, layer 3, sitting right against the joint itself.
Layer 3 is the thick joint capsule itself, the lateral collateral ligament, or LCL, and a complex of much smaller, highly specific stabilizers at the back corner, like the arcuate ligament and the fibellofibular ligament.
So that is the lateral onion. IT band on the superficial outside, LCL buried deep on the inside. What about the medial side, the inside of the knee?
It follows a very similar 3-layer onion concept, but with entirely different structures. Medial layer 1 is the sartorius muscle and its fascia. Medial layer 2 contains the superficial medial collateral ligament, or MCL, the posterior oblique ligament, the semimembranosus tendon, and a very crucial structure, the medial patellofemoral ligament, or MPFL.
Why is the MPFL so crucial to highlight in layer 2? What happens if it breaks?
Because it is the primary restraint against patellar dislocation. If a patient violently dislocates their kneecap, which mechanically almost always pops outward laterally, it is the MPFL in medial layer 2 that gets stretched and violently torn. It is the main seatbelt holding the kneecap from flying off to the side of the leg.
Wow. Okay, and layer 3?
Finally, medial layer 3 is simply the deep portion of the MCL and the joint capsule itself.
Okay, so we've got the onion layers wrapping the outside of the joint. Let's look deep inside the dark center of the knee, right between the condyles, where things get a bit like an alphabet soup. The meniscofemoral ligaments, the Humphrey and Risberg ligaments. I guarantee every surgical candidate listening has flipped these 2 in their head at least once during a mock exam.
It is the ultimate multiple-choice exam trap because they are nearly identical structurally. Both of them are tiny fibrous bands that run from the posterior horn of the lateral meniscus diagonally up to the medial femoral condyle. They both run right alongside the massive posterior cruciate ligament, the PCL. One runs slightly in front of the PCL, one runs slightly behind it.
So how do you possibly remember which is which under the blinding stress of an exam?
You use the alphabet memory trick. The names of the ligaments are Humphrey and Risberg. The anatomical positions are anterior and posterior.
Okay, I'm tracking.
In the English alphabet, the letter H comes before the letter W. Similarly, anatomically, the position anterior comes before posterior. Therefore, Humphrey is anterior to the PCL. Risberg is posterior to the PCL.
H before W, anterior before posterior. Humphrey's in front, Risberg is behind. That is an incredibly clean mnemonic. Memory palaces are absolute lifesavers when the anatomy gets this granular. Let's talk about the most famous ligament inside the knee, the one every single athlete fears tearing, the ACL, or anterior cruciate ligament.
The ACL is fascinating from a biomechanical standpoint because it is not just one thick uniform rope. It is actually composed of two distinct bundles of collagen fibers that work together dynamically as the knee moves through its arc of motion.
Two bundles, how do they behave differently?
You have the anteromedial bundle and the posterolateral bundle. They tense up at completely different times depending on the angle of your knee. The anteromedial bundle is tightest when the knee is in deep flexion, when it is fully bent. The posterolateral bundle is tightest when the knee is in full extension, when it is straight.
Which is brilliant engineering, because it means no matter how you move your knee, whether you are squatting or standing, at least one part of the ACL is actively guarding the joint, stopping the tibia from sliding forward out from under the femur. Where does a structure like that get its blood and nerve supply? It is essentially floating in the middle of joint fluid.
It has a highly specific, dedicated pipeline. The blood supply to the ACL comes directly from a specific branch called the middle geniculate artery, and its nerve supply, which is crucial for proprioception, telling your subconscious brain exactly where your knee is in space, comes from a tiny branch of the tibial nerve.
Is there a specific telltale radiographic sign on an MRI if someone ruptures their ACL? An examiner's favorite discriminator.
Yes, there is an incredible clinical pearl called the kissing lesion. When the ACL violently snaps, the tibia is instantly unrestrained and it violently shifts forward. In that microsecond of instability, the heavy femur crashes down onto the back of the tibial plateau.
Ouch.
This collision leaves a distinct, bright bone bruise on the femur, specifically located at a subtle anatomical indentation called the sulcus terminalis on the lateral femoral condyle. If an examiner shows you an MRI with a bright white bone bruise on the sulcus terminalis, you almost certainly have a blown ACL.
That is a phenomenal piece of anatomical detective work. The bone bruise literally tells the story of the ligament failure. If you only remember one thing about the layers and ligaments of the knee, lateral layer 1 consists of the IT tract, the biceps femoris, and the fascia. The MPFL, the kneecap seatbelt, lives in medial layer 2. Using the alphabet trick, the Humphrey ligament is anterior to the PCL while Risberg is posterior, and the ACL receives its critical blood supply from the middle geniculate artery.
The anatomy is locked. Now we have to look at how that anatomy actually moves.
Which brings us to knee biomechanics and the popliteal fossa. Having just painstakingly built the ligaments and layers of the knee, we now have to look at how they dictate movement. The knee is not just a simple, rusty door hinge swinging back and forth, is it?
Not at all. If it were a simple hinge, the massive forces of walking and running would grind the cartilage to dust in a matter of months. The biomechanics of the human knee are a highly complex, beautifully orchestrated combination of rolling, gliding, and spinning. And the absolute masterpiece of this system is the screw-home mechanism.
The screw-home mechanism. Walk me through what that actually looks like when I move my leg.
Try this. Sit in a chair and slowly straighten your leg out in front of you. As your knee approaches the final 15 degrees of extension, as it gets perfectly rigidly straight, the lower leg bone, the tibia, automatically twists or externally rotates, about 5 degrees relative to the femur.
Wait, it actually spins outward right at the very end. Why does it do this mechanically? Is there a twisted ligament pulling it?
No, it is entirely dictated by the asymmetrical, mismatched shape of the bones themselves. The cartilage tract of the medial tibial plateau, the inside shelf of your shin bone, is physically longer from front to back than the lateral side.
So they are running on mismatched track.
Exactly. As the round condyles of the femur roll forward to straighten the leg, the lateral side finishes its short track early and hits a wall. But the medial side still has more track left to cover. So the femur essentially runs out of road on the lateral side, causing the entire knee system to pivot around that stopped point. This physical asymmetry forces the tibia to externally rotate to finish the movement.
And what is the biological benefit of this twisting motion? Why did we evolve a crooked track?
Supreme energy efficiency. When the tibia externally rotates those final 5 degrees, it tightly twists all the major ligaments of the knee, the collaterals on the sides and the cruciates in the middle, until they are completely rigidly taut. It physically locks the knee joint into a stable, unbending pillar. Because of the screw-home mechanism, you can stand perfectly straight for long periods of time with almost zero muscular effort from your heavy quadriceps muscles. Your skeleton and ligaments are carrying the load, not your muscle fibers.
Bipedalism strikes again. We traded a simple hinge for an energy-efficient lock. But here's the problem. If the knee is physically locked tight by twisted ligaments, how do you ever bend your knee to take your next step? You can't just power through rigid, locked ligaments without tearing them.
You need a key to unlock the mechanism. And that biological key is a small diagonal muscle at the very back of the knee called the popliteus. When you want to bend your knee to take a step, your brain fires the popliteus muscle first, a fraction of a second before the hamstrings.
And what does it do?
The popliteus contracts, internally rotates the tibia back those 5 degrees, untwists the ligaments, and successfully unlocks the joint so flexion can smoothly begin.
So the passive screw-home mechanism externally rotates the tibia to lock the knee. The active popliteus muscle internally rotates the tibia to unlock it. What happens mechanically as you continue to bend the knee past that initial unlock?
That introduces the second major mechanical concept examiners love, femoral rollback. As you bend your knee deeply, like going into a deep, full squat, the round condyles of the femur don't just spin in place like a wheel spinning in mud. If they did, the back of your femur would crash right into the back of your tibia, severely limiting your motion.
Makes sense.
Instead, the condyles simultaneously roll backward and slide forward on the cartilage.
A synchronized rolling and sliding mechanism.
Yes. And again, because of the asymmetrical shape of the joint, the lateral condyle rolls backward much further than the medial condyle, which acts more like a static pivot point. This complex spinning rollback is what allows you to achieve deep, acute flexion without the bones levering themselves completely out of the socket.
Okay, let's look behind all this incredible machinery. Behind the knee joint is a diamond-shaped hollow space called the popliteal fossa. And just like the sciatic notch in the pelvis or the tracheo-esophageal groove in the neck, it is packed with critical nerves and vessels passing from the thigh down into the calf.
It is a densely packed, highly vulnerable transit hub. And the examiner's playbook demands we know exactly where the most at-risk structures lie within that diamond.
So let's map the hazards. What is the superior lateral hazard? If a surgeon is working on the upper outer edge of the back of the knee, what is directly in the crosshairs?
The most lateral structure up top is the common peroneal nerve, which is also known as the common fibular nerve. I'm going to state that twice because it is perhaps the single most famous nerve injury in all of lower limb orthopedics. The most lateral structure in the upper popliteal fossa is the common peroneal nerve.
Why is this specific nerve so incredibly vulnerable to injury?
Because of its terrifyingly exposed evolutionary pathway. It runs right down the medial border of the biceps femoris tendon, and then, to get to the front of the leg, it immediately wraps itself around the superficial bony neck of the fibula, the small, thin bone on the outside of your lower leg just below the knee.
Right on the bone.
At that exact point, it sits right under the skin, directly against hard bone, with almost zero fat or muscle to cushion it.
Which means any pressure from the outside crushes it violently against the bone.
Exactly. If an orthopedic plaster cast is applied too tightly around the knee, or if an unconscious patient lies awkwardly with their leg pressed against a hard metal bed rail for a few hours, the common peroneal nerve is instantly compressed and damaged. The clinical result is a total loss of the ability to lift the foot. A devastating, dragging condition called foot drop.
That is a brutally unforgiving anatomical design. It's a literal evolutionary choke point. What about the structures running straight down the deep center of the popliteal fossa?
Deep in the exact center, you have the main vascular supply to the lower leg. And examiners will test exactly how they are stacked from superficial, closest to the skin, to deep, closest to the bone.
Common sense tells me the artery, the highest pressure, most vital vessel, would be the deepest, most protected structure right against the bone. Is that how it's stacked?
Your common sense is perfectly aligned with the anatomy. From superficial to deep, the stack order is nerve, vein, artery. The tibial nerve is the most superficial, closest to the skin. Below that is the popliteal vein. And the absolute deepest structure, pinned tightly against the back of the femur and the rigid knee joint capsule, is the popliteal artery.
Which perfectly explains why a severe knee dislocation, where the tibia violently shifts backward or forward relative to the femur, is such a nightmare. It frequently shears the popliteal artery completely in half. The artery is completely tethered to the bone. It has nowhere to run when the bones shift.
Precisely. A knee dislocation is not just a ligament injury. Because of that deep anatomical tethering, it is a limb-threatening surgical vascular emergency.
If you only remember one thing about knee biomechanics and the popliteal fossa, the passive screw-home mechanism externally rotates the tibia to lock the knee for efficient standing, and the active popliteus muscle unlocks it. The common peroneal nerve is the most lateral structure in the upper popliteal fossa, making it highly vulnerable to compression at the fibular neck.
The knee is complete.
All right, take a deep breath. We have covered a massive amount of incredibly dense, high-stakes anatomical real estate today, from the neck down to the knee. It is time to lock it all in. We're going to finish this deep dive with a final lightning round.
Oh, I'm ready.
This is a highly energetic, fast-paced lap of the entire session to cement those synapses right before you walk into the exam room. I'm going to ask the rapid-fire questions. You give me the instantaneous answers. Ready?
I'm ready. Let's fire.
Anterior cervical spine approach. What is the classic nerve danger, and which side is safer to operate on?
The recurrent laryngeal nerve. The left side is safer because its path under the aorta is predictable.
Lumbar spine. What is the L3, L4 exiting route, and which specific vein absolutely must you ligate for L4, L5 anterior access?
L3 is the exiting route. You must ligate the short, fat iliolumbar vein.
Which specific part of the intervertebral disc is totally, completely insensate?
The internucleus pulposus has no nerve endings, only the outer annulus and periosteum feel pain.
Dermatome anchors down the leg. Where are L4, L5, and S1?
L4 is the medial leg, L5 is the lateral leg and big toe extension, S1 is the lateral foot.
Which two hip surgical approaches are absolute traps because they have no true internervous plane?
The Watson-Jones and the Hardinge. They both involve muscles supplied by the superior gluteal nerve.
In the anterior Smith-Peterson approach, what is the specific danger artery crossing the plane?
The ascending branch of the lateral femoral circumflex artery.
Where exactly does the sciatic nerve exit the pelvis, and what is the catastrophic bone graft danger at the top of the notch?
The sciatic nerve exits the greater notch below the piriformis. The bone graft danger is tearing the superior gluteal artery.
What is the main blood supply keeping the femoral head alive, preventing a vascular necrosis?
The medial femoral circumflex artery.
Inside the knee, the meniscofemoral ligaments. Humphrey versus Risberg.
Use the alphabet trick. Humphrey is anterior to the PCL. Risberg is posterior to the PCL.
And finally, what is the most lateral structure in the upper popliteal fossa vulnerable to a tight cast?
The common peroneal nerve.
Done. An absolute masterclass in high-yield surgical anatomy.
Before we sign off, I want to leave you with a fascinating narrative through line that emerged over and over as we went through this deep dive. Look at the specific repeat offenders we just hammered. The superior gluteal nerve causing a limp in the hip. The medial femoral circumflex artery feeding the femoral head. The common peroneal nerve wrapping exposed around the fibular neck.
They came up again and again as the ultimate surgical traps. Why are these specific, seemingly random structures so relentlessly heavily tested by examiners?
Because surgical anatomy isn't just about memorizing static maps from a textbook, it is fundamentally about understanding human developmental vulnerability. Look at bipedalism. As human beings evolved to stand fully upright on two legs, our pelvis had to dramatically reshape itself to bear weight, and our knee joints had to develop mechanisms to lock out efficiently.
Right, our structural mechanics radically shifted from our primate ancestors. We completely changed the architecture of the bones.
Exactly. And when those massive bones shifted and rotated to support bipedal walking, the existing nerves and blood vessels had to be stretched, pulled, and routed around these new massive bony corners. These nerves and vessels now cross highly transitional zones where our bipedal evolution essentially created intense anatomical choke points.
Wow, so the superior gluteal nerve isn't just a trap in a surgical textbook. It is a vulnerable choke point created by the massive muscular expansion required to keep a human pelvis level while walking on two legs.
Precisely. And the common peroneal nerve is exposed on the outside of the knee because the complex biomechanics of the lower leg bones require it to route superficially to get to the front of the shin. When you realize that the examiner's playbook is basically just a map of our evolutionary compromises, the anatomy stops being a sterile list of Latin names to memorize and starts becoming a cohesive story of how the human machine was actually engineered.
That is an incredible lens to view this through. The traps are just evolutionary choke points. It gives a whole new gravity to where you place the scalpel. Thank you for walking us through this absolute labyrinth.
It has been an absolute pleasure.
That is a wrap for this session. The examiner's playbook, planes, dangers, and bony landmarks is yours to use. Next time, we're launching part 2 of this applied anatomy deep dive, moving our focus up to the upper limb. We will be untangling the terrifying web of the brachial plexus, navigating the complex shoulder joint, and mapping the danger zones from the quadrangular space all the way down to the hand. We will see you there.